So the objective of this presentation is to review the pertinent trials that establish the role of radiation therapy in endometrial cancer. We are going to look into the treatment of the recurrent endometrial cancer by radiation therapy and review some guidelines in radiation oncology. Apart from being a radiation oncologist, I have nothing else to disclose. You are going to encounter those abbreviations throughout the presentation. RT stands for external beam radiation therapy, VBT for vaginal brachytherapy, just to mention a few, and they are very self-explanatory. Surgery remains the principal treatment. It is performed by TAH, BSO, with or without staging. Nowadays, robotic laparoscopic surgery is gaining more popularity. Primary radiation therapy is given for the patients who are surgically unfit. In early stages, brachytherapy alone could be sufficient. In more advanced stages, we use combination of external beam radiation therapy and brachytherapy. Adjuvant therapy is given by either radiation therapy alone or combination of chemo and radiotherapy and chemotherapy alone. Let's spend a couple of minutes on radiotherapy as a treatment modality with the coverage of some basics and delivery of such treatment. We all know that the unit of radiation therapy is 1 gray, and this is energy absorbed per unit mass. The smaller unit is 1 centigrade, which is 100th of a gray. It's basically, you are going to see also in quite a lot of publications, the rad. Rad is an antiquated unit and is equivalent to 1 centigrade, and basically is an acronym which says radiation absorbed dose. Here are several dose fractionation schedules: 45 grays in 25 fractions over 5 weeks, 46 grays in 23 fractions over 4.5 weeks, 50.4 grays in 28 fractions over 5.5 weeks. The latter two are basically the fractionations used at the Portec trials and the GOG99. There are also some different schedules for brachytherapy. If the brachytherapy is used as monotherapy, 21 grays in 3 fractions given by high-dose rate brachytherapy and given weekly is the schedule. Then if you give it continuously, you can give 30 grays of low-dose radiation. 30 grays in 3 fractions is a monotherapy for carcinoma of the endometrium. If you use it as a HDR boost or high-dose rate boost, you can use 6 grays in 1 fraction or 12 grays in 2 fractions. So let's start with the treatment from outside, so-called teletherapy. The process starts with the CT simulation where the patient is placed in the treatment position, and basically you put the foam wedge under the knees for stability and immobilization. The next step is planning, which starts with contouring by radiation oncologists on CT slices. Those are the axial, coronal, and sagittal slice. And please observe the delineation of the targets. You can see the target around the primary, target around the nodes, also organs at risk like rectum, bladder, and small bowel. For simulation, we also use a removable vaginal marker. You can see it right here. This actually gives us the delineation of the vaginal wall. Many radiation oncologists and residents are using these guidelines for contouring targets, so the contouring is done pretty much uniformly across North America. After contouring is completed, a dose distribution is generated. Please observe the dose distribution around the targets. So you can see around the nodes here, around the primary. We also create the dose volume histograms, and we give the dose statistics for the targets and organs at risk. In cases of stage 3 CDCs, one would consider treatment of the para-aortic chain as well. Even in stage 3 C1 with pelvic confined nodes, unless a thorough para-aortic nodal dissection is performed, there is more than 50% chance of nodal involvement. This is an example of extended field radiation therapy. We go up to the T12. Technique here which is used is intensity modulated radiation therapy. If your department does not have the IMRT capabilities, a 3D conformal radiotherapy is a very acceptable alternative. Recently, we published our experience comparing the two modalities, and there was no difference in both acute and long-term toxicity with similar treatment outcomes. After plan is generated and approved, the patient is sent for treatment. This is an image of linear accelerator. Please observe also we have something called onboard imaging. This onboard imaging is cone beam CT and gives tracks of the changes in targets daily. Brachytherapy is the other way of delivering radiation therapy. It is usually used in combination with the external beam radiation in order to deliver a boost to the area of highest risk of recurrence. For example, the vaginal wall. It can be also given as monotherapy. It was used in Portec 2 trial. Why is this called after order? Because the source is housed here and then travels into the patient through the cable. once when all the personnel has vacated the premises. Thus, there is no exposure to the staff. This is an example of 7-channel applicator in place. You can see the red cloud around the applicator, which delineates the target of the upper 4 centimeters of the vagina and ½ centimeter away from the applicator itself. Similar to the external beam radiation therapy, a dose distribution around the applicator is generated. Please observe the rapid dose fall-off as a factor of distance from the source, with 100% isodose in red and 50% isodose in blue, only 1 centimeter beyond. Also, all the organs at risk are getting much smaller dose than the target itself. Here is the image of applicator in place secured by elastic panties, which we use in this institution. If you compare it to the clamp is actually rigidly attached to the bed. The panties allow some patient's movement without dislodging the applicator. A good old mark on the skin always is just there to secure the proper position of the applicator. We can also get creative. This is an example of the cylinder in place, and you can see actually on the side, there is a loose catheter which fits very well in patients' post-operatively created left recess. There are a couple of other applicators on the market. The best one is the Capri variant applicator, which is an inflatable applicator which conforms very well with the anatomy of the vagina. Unfortunately, the downsides is such a single use and is extremely expensive. The other one is reusable multi-channel. The Philips applicator has 9 channels. The good thing about that is actually the converging of the sources for the better coverage of the vaginal wall. After all these technical details, here are some retrospective clinical data. If one uses brachytherapy alone, one could expect relapse rate between 0 to 10%. For the 2 studies with a high recurrence rate, it is important to note that the dose that the Thomas and co-workers did not state the dose or prescription point, and Weiss did not prescribe 3 times 7 grays to the surface, thus underdosing the area at risk. Below are the results of the larger series, of course retrospective, of brachytherapy alone with the low rate of vaginal recurrence, and the highest rate was 2.7%, which was including also some pelvic recurrences. For surgically unfit patients and stage 1 endometrial cancer, brachytherapy as monotherapy is a suitable option. This is our study for McGill for that population of patients. We had 38 patients with median follow-up of almost 5 years, 15-year disease-specific survival of 78% for all stages, 90% for stage 1, and 42% for stage 2. 15 years disease-specific survival was 91% for grade 1 and 67% for grade 2 and 3 combined. This was statistically significant. Most of the patients were treated without proper imaging like MRI. For the 11 patients who were actually treated with MRI guidance, the control rate is at 10 years is 100%. The toxicity rates are also quite low. 4 patients experienced late toxicity, 1 experienced grade 2, and 3 experienced in grade 3 and 4, and all of them were in no image-guided brachytherapy group. Radiation therapy comes at a price. Acutely, from teletherapy, somebody can experience fatigue, can have diarrhea, dysuria, and nausea and vomiting, which is really field-dependent. If you treat the para-aortic field, that is a reality. For brachytherapy, the patient can have some pain, bleeding, and vaginal perforation. Vaginal perforation is quoted in literature up to 2% incidence, and it has increased lately with the advent of robotic surgery. It occurs during examination, during the procedure, or following the procedure, and is usually a result of vaginal wall dehiscence. For the late side effects, we have vaginal stenosis, changes in bowel habits, diarrhea, urgency, intolerance to certain food, chronic cystitis, proctitis, and bowel obstruction and perforation. Bowel obstruction and perforation, fortunately, happens extremely rarely, and we quote it to 1% or less. Vaginal stenosis is the most common long-term side effect of pelvic radiotherapy. It also occurs with external beam radiation therapy alone, and the example for that is actually carcinoma of the anal canal. It makes future intercourse difficult, if not impossible, and same is true with vaginal examination for follow-up. It can be easily prevented by regular use of vaginal dilators, if not sexually active. We recognize that the majority of the patients are elderly and are not interested in sexual intercourse. We recommend the regular use of 3 to 4 times per week, up to 5 minutes, and no less than 2 years. So please encourage your patients to use the vaginal dilator. Even though some of the patients may have some vaginal bleeding during the use of dilator, this is not the reason to stop it. I know that it's very unsightly and patients feel very uncomfortable with that, but for the benefit of vaginal health, it's very important to continue using it. Now let's go to the studies that established radiation therapy as adjuvant modality in early endometrial cancer. This very busy slide is a summary of all the randomized trials of adjuvant radiation therapy in early stages of endometrial cancer. They are the Norwegian, the Dutch, European studies, the North American, the British, Canadian study, and the Swedish trial. All of them showed consistently improved local control here in bold letters, but none of them showed evidence of improvement of survival. Please note also that 99 patients from the PORTEC trial were actually excluded because despite getting radiation therapy and having excellent local control, the distant relapse becomes a real issue. Those are the references of the previous trials. Here are the trials that establish the role of brachytherapy in adjuvant setting. Those are the two Swedish trials and the Dutch European trial. The first Swedish trial actually looked at the patients who had high intermediate risk and high risk in the endometrial cancer 1C grade 3, and they combined vaginal brachytherapy plus or minus external beam radiation therapy. Despite statistically significant improvement in local regional control with combined external beam radiation and brachytherapy, the absolute difference was up to 5%. There was no difference in overall survival. It also came at the price of more gastrointestinal, urinary, and vaginal and late side effects. The second trial was vaginal brachytherapy used just in the early endometrial cancer, stage 1A and B, and grade 1 and 2. The last is our STAR trial, and we are going to talk about that in more details later. Again, those are the references for the trials. So let's try with the landmark trials one by one. First trial is the Norwegian trial, or known as Alders trial, which was reported back in 1980 and is often quoted as a basis for radiation therapy. They had 540 patients. They had no lymph node dissection, and all of the patients got vaginal brachytherapy, 6,000 rods. They were randomized to observation or adjuvant radiation therapy. At the time, they used high voltage, 4,000 rods in 20 fractions, with midlight block at 2,000 rods. So with a follow-up more than 20 years, it showed improved in local control with radiation therapy. External beam radiation therapy was given with absolute value of 5%, but there was no impact on overall survival. On the other hand, there was increase in extrapelvic recurrence and increased incidence of second cancers in radiation therapy arm. For women younger than 60 years of age, there was higher mortality rate noticed in external beam radiation therapy and almost double of the incidence of second cancers. It is also important to mention that two patients in radiation therapy arm died from the radiation therapy, but it must be something related to the technique used at the time. Just a quick reminder, what was the staging system used at the time? Surgeon would remove the uterus, slice it open, measure the tumor, and depending on the length, less or more than 8 centimeters, one was diagnosed with either stage 1A or B disease. Moving to more modern studies, this was originally reported in JCO in 2004 and updated in Red Journal in 2011. PORTEC trial had, again, surgically unstaged patients, 714 patients, randomized to observation or adjuvant radiation therapy, 46 grays in 23 fractions with no brachytherapy. Just a quick reminder of the staging system at the time, and please focus on stage 1. Stage 1 was defined 1A, B, and C, depending on the depth of myometrial invasion and involvement of the endometrium. This is a tabular representation of inclusion criteria. Stage 1C, grade 3, was excluded, as mentioned before. There was no papillary serous or clear cell histology allowed for the study. With a 15-year follow-up, there was almost 10% reduction in local regional recurrence. There was 8% reduction in vaginal recurrence. And similar to Alders trial, there was increased incidence of distal metastasis in the radiation therapy arm. In general, there was a poorer overall survival in radiation therapy arm, but there was no statistically significant. Poorer overall survival was also noticed in patients who actually received the radiation therapy before. Since the radiation was already given, the salvage options were limited. Also, with a 15-year follow-up, there was increased incidence of second malignancies in radiation therapy arm, 55 versus 42. Other comments on the PORTEC trial: 1/3 of the patients were in the low risk category. 6% of the patients did not receive the prescribed radiation therapy as per protocol. Almost 2% of patients in control arm received radiation therapy. Patients with lymph node dissection were excluded since in Europe most of the cancer surgeries were performed by general gynecologists who do not regularly perform lymph node dissection. The question of importance of lymph node dissection was addressed later on in Aztec trial. Now, one thing which is extremely important to understand, the late side effects were only 2% versus, let's say, 8%, which was present in the GOG-99 because of much less extensive surgery in the pelvis, and we know that adding radiation therapy to the extensive pelvic surgery increases the risk of morbidity. Moving to the GOG-99 trial, those are all surgically staged patients, and they had pelvic and selective para-aortic lymph node dissection plus peritoneal cytology. 81% of the patients met eligibility criteria, so that basically really excluded all the patients with higher stages of disease. They were randomized to pelvic radiation therapy, 50.4 grays in 28 fractions, or observation. 1/3 of the patients were classified at high intermediate risk criteria by the criteria established from GOG-33, where the recurrence rate was 25% if patients were left untreated. Please note that the study did include actually the high risk 1C grade 3 disease, and they also had about 9.5% patients who had occult stage 2 disease in both arms. With the median follow-up of 69 months, locoregional and local recurrence either in vagina or pelvis, and vagina and pelvis was 15.3% versus 6.8% in favor of the external beam radiation arm, with absolute difference of 8.5%. Unfortunately, that came with a price of the toxicity, and the difference in grade 3 and 4 toxicity from GI, GU, hematological, and skin toxicity were statistically significant. Couple of more thoughts about the GOG-99. Despite 2/3 of the patients were in the intermediate risk group, the cumulative incidence of recurrence was decreased by 9% in radiation therapy arm. When we look just particularly at the high intermediate risk, the incidence actually of recurrence was dropped by 20% in radiation therapy arm. Also, vaginal recurrence rate was decreased about 5%, and pelvic and vaginal recurrence rate by 8%. 2 patients who recurred in the radiation therapy arm actually did not get the prescribed radiation therapy, but they were included in intention to treat analysis. What came out of both of the trials is definition of high intermediate risk group, which was defined as a risk of recurrence of 20 to 25% at 5 years if left untreated. Portek defined it as more than 50% myometrial invasion, older than 60 years of age, grade 3 histology, and somebody had 2 out of 3 factors present. There was recurrence rate of 20% if left untreated. On the other side, GOG-99 had a grade lymphovascular space invasion, outer third of myometrial invasion as risk factors. If the patient was 50 years or older and has 2 risk factors, or 70% or older has 1 risk factor, the recurrence rate was 25% at 5 years. Those are the stratification criteria for future trials. Next trial is the combined Canadian and British trial, Aztec-EN5 trial. They had intermediate or high-risk patients who had total abdominal hysterectomy and bilateral subcircumferectomy, plus or minus staging. 900 and so patients were randomized to observation, plus or minus brachytherapy as per center policy, or adjuvant pelvic radiation therapy, 45 grays in 25 fractions, plus or minus brachytherapy. Those are the eligibility criteria. You can see they also included papillary serous and clear cell histology, and there are high intermediate risk as well as high-risk patients present there. So 76% of the patients in this group were high intermediate risk, and an additional 11% patients had high-risk subgroup which were excluded from the Portek 1 trial. They also included 11% of papillary serous and clear cell histology. The primary endpoint was overall survival. The secondary endpoint was disease-free survival and treatment toxicity. Now, those are the patient characteristics. Please observe one very important thing. Actually, 51% of the observation arm did receive brachytherapy, so this is not observation any longer. At 5 years, there was no difference in overall survival, relapse-free survival, or recurrence rate. There was no subgroup analysis performed. Despite brachytherapy was used in 51% of the observation arm, they still did notice an absolute 3% increase in vaginal pelvic recurrence in observation arm, which was statistically significant. Last of the START trials in adjuvant radiation therapy in early stage endometrial cancer is the Portek 2 trial. They had again patient group with no lymph node dissection who were randomized to adjuvant radiation therapy, 46 grays in 23 fractions to the whole pelvis with no brachytherapy, or brachytherapy by high dose rate 21 grays in 3 fractions, low dose rate 30 grays, continuous dose rate of 50 to 70 centigrays per hour. and the dose was delivered to the proximal half of the vagina at 5 millimeter depth. The endpoints were efficacy, side effects, and health-related quality of life. They picked up indeed their high intermediate risk group of patients defined in the previous trials. Again, they did not have papillary serous or stage 1C grade 3 patients. With the median follow-up of 45 months, an estimated 5 years rate, keeping in mind that these patients did not have lymph node dissection, there is an increase in pelvic relapse with absolute difference 3%, but that did not reach actually statistical significance. Again, there is no statistically different improvement in overall survival, but in favor this time in vaginal brachytherapy. Patient in vaginal brachytherapy group reported better social functioning with lower symptom scores of diarrhea, fecal incontinence, and limitation of daily activity due to bowel problems and the need to stay close to the toilet. After 7 years of follow-up, there was no more difference in global health, social functioning, but there was still statistical difference in diarrhea and urinary urgency. So in conclusion, adjuvant radiation therapy, either by the external beam radiation therapy or vaginal brachytherapy, improves local and locoregional control in all, and especially in high intermediate risk patients. There is no impact on survival. There is no difference in local control between pelvic external beam radiation therapy or vaginal brachytherapy, but there was certainly less toxicity observed in vaginal brachytherapy. So let's switch gear to more aggressive uterine cancers and look at the randomized trials of radiation therapy in this population. Another busy slide. This is a summary table of all the randomized trials in high-risk uterine cancer. They are color-coded for better understanding. Those are the trials of radiotherapy versus chemotherapy, radiotherapy and chemotherapy versus radiotherapy alone, and different combination of chemotherapy. Only one trial, the GOG 122, showed improvement in overall survival, and another trial, NSGO EORTC, shows statistically significant difference in progression-free survival if combined chemoradiation therapy was used compared to radiation alone. Again, references for the previous trials. So now let's have a closer look at the GOG 122 trial, known also as Randall's trial. This is a trial that made justification also for adjuvant use of chemotherapy in high-risk endometrial cancer. So almost 400 patients were randomized to vaginal, the whole abdominal radiation therapy and pelvic boost, comparing to chemotherapy, this time use doxorubicin and cisplatinum, every 3 weeks for 7 cycles, followed by 1 cycle of cisplatinum. This is how the whole abdominal field looks like. The dose prescribed here is 30 Grays in 20 fractions, and anybody who knows anything about radiation therapy would consider that insufficient to eradicate even macroscopic disease. And additional boost was given to 15 Grays in 8 fractions to the pelvis and to para-aortics if needed. They indeed included all the high-risk patients, with 20% of those patients having papillary serous or clear cell histology. With a median follow-up of 74 months, progression-free survival and overall survival at 5 years is better in chemotherapy group, with an absolute difference of 12% and 13% respectively. And that was statistically significant. But unfortunately, that came at a price. 5 patients in the radiation therapy arm and 8 patients in the chemotherapy arm died caused by the side effects of their treatment. So let's look in some data of non-randomized trials published to date in high-risk patients. This table came from the study we recently published on our patients with trimodality treatment, surgery followed by chemotherapy, followed by radiation therapy. Again, we had 38 patients. I think McGill likes the number 38, who were evaluated, and at 5 years, overall survival was 76%, and disease-free survival was 72%. All of the 9 patients who recurred, they actually recurred systemically. The only 2 of those patients recurred really in the radiation field, one in the vagina and one in para-aortic chain. In univariate analysis, the only predictor for relapse was grade, and in multivariate analysis, it was the start of radiotherapy following chemotherapy. Please observe also that it's very interesting 2 trials from Secord actually had different schedules of chemotherapy, radiation therapy followed by chemotherapy, radiation therapy followed by chemotherapy, or chemotherapy and followed by radiation therapy. And they were all stage 3 and 4 disease, and still, actually, despite this high stage of disease, they have very respectable both local control and overall survival, especially the SECORD trial of sandwich chemo, radiation chemo, with median follow-up of 3 years that have disease-free survival of 73% and overall survival of 90%. When we look exclusively at the sandwich approach, chemotherapy, radiation therapy, chemotherapy, we have similar overall survival between 54% and 90%, the disease-free survival of 52 to 73%. Now that actually compares very favorably with survival reported in this group of patients, which is usually quoted around 50% or less. We are anxiously awaiting for the results of these trials in high-risk uterine cancer. PORTEC-3 trial had 670 patients with stage 1 to 3 disease with high-risk features, serous and clear cell histology. Their standard arm was pelvic radiation therapy compared with chemoradiation, followed by 4 courses of carbotaxol. This is a very interesting GOG trial 249, which had 562 patients with stage 1 and 2 high intermediate risk or clear cell and serous histology. They were randomized to pelvic radiation therapy compared to vaginal brachytherapy, followed by carbotaxol times 3. The GOG 258 was just completed recently, had 804 patients with stage 3 and 4 disease, and their standard arm was from the Randall's trial was chemotherapy. This time the chemotherapy was substituted to carbotaxol, comparing to the pelvic chemoradiation therapy followed by carbotaxol times 4. In conclusion, we still have problems controlling the high-risk uterine cancer. Treatment with pelvic radiotherapy alone certainly is not enough. Since the combination of radiotherapy and chemotherapy seems to be very well tolerated, the rationale of using the combination is that radiation should treat local disease and chemotherapy should address distant metastasis. Unfortunately, the sequencing of chemotherapy and radiotherapy, like chemo first, radiotherapy second, or vice versa, or some sandwich combination, is not going to be answered with the current trials. To summarize, we differentiated 3 main risk groups, low, intermediate, and high risk. The intermediate risk group is subdivided in low intermediate and high intermediate risk. The importance of classification has implication on need and selection of adjuvant treatment. The risk categories are also reflected in the survival. The last column is based on the FIGO 2009 staging system and shows a significant decline in survival as the stage increases. Now, if you look at the survival based on the risk groups, there is an overlap because of the adverse prognostic factors like grade, age, histology, and presence or absence of lymphovascular space invasion. Thus, this staging system is also not ideal. So let's spend some time on the recurrent disease. We know that if patient recurs, 90% of them are going to do so in the first 2 years. Endometrial cancer patients who did not receive pelvic radiation therapy could experience both pelvic or para-aortic nodal recurrence. Up to 20% of the patients in early stage and up to 50% of patients in advanced stage disease will recur. Most common recurrence is the pelvic, with 1/3 of patients are going to recur distantly. Unfortunately, there is no consensus in management of recurrent disease, and every center does something what they think is right for the patient. Certainly, this is due because there is no level 1 evidence to base your treatment on. 70% of patients are symptomatic at recurrence. That should trigger further evaluation. Unexplained vaginal bleeding or discharge is the most common problem, and detection of mass in vaginal examination is the second most common. There are also some prognostic factors when the patient recurs. The site of recurrence is very important, grade and histology and disease-free survival, and also the history of previous radiation therapy. Vaginal recurrence carries the best survival rate and prognosis versus para-aortic, which actually has a very high chance of distant metastasis. The lower the grade, the better is the prognosis comparing to, let's say, higher grade or papillary serous, papillary or clear cell histology. Disease-free survival pretty much reflects the biology of the disease itself. Previous radiation therapy is also important, as we noticed in the PORTEC trial. Patients who had previous radiation therapy had much worse overall survival at recurrence. Those are the minimal investigations we should do for the patients. I put a question mark at CA125 and the human epididymis factor, since there is no established value of those markers in detecting endometrial cancer recurrence. For example, CA-125 could be very useful if elevated only to track the progression of the disease post-treatment, but it's not so useful if it's low at the beginning. I placed also the investigation in order from the highest sensitivity and specificity. PET scan, with reason, was placed first. It's really a metabolic activity indicator rather than an anatomical one, and also gives you a good idea what's going on with the patient's bony status. Similarly, Society of Gynecologists and Oncologists rates symptoms as the first sign of recurrence, followed by examination. We can see the usefulness of PET scan in detecting recurrence. Now, does it translate in survival of the patients? We don't really know. So, for recurrent disease, speaking of surgery, we do not have evidence that surgical removal or debulking is of any more benefit than higher dose of radiation therapy. There is, of course, a theoretical advantage if the recurrence is in front of the vital structures like kidneys or sensitive organs like bowel. Surgery is treatment of choice in the patients who received previous radiation therapy. Radiation therapy is certainly a mainstay of salvage if patient did not receive it in the past, and can also be given in adjuvant to salvage surgery, including intraoperative radiation therapy. Now, keep in mind that intraoperative radiation therapy carries a very high risk of complication, including fistula formation, nerve damage, and bowel toxicity. Radiation therapy is excellent palliative modality, which palliates bone disease. It palliates also if somebody is bleeding, and certainly if somebody has brain metastasis, provides very quick resolution of symptoms and improves quality of life. It's not the scope of this presentation to talk about chemotherapy and hormonal therapy, but in most situations, it's purely palliative. So, in our institution, we use the following schedule for the recurrence. Thank you very much. Radiation therapy to the whole pelvis, followed by vaginal brachytherapy prescribed at tumor depth. Interstitial brachytherapy for deeper tumors. Radiation therapy dose is 45 Grays with concomitant boost to 55 Grays in 25 fractions. And brachytherapy dose is 3 × 6 Grays prescribed at the depth. This is an example of early salvage of carcinosarcoma, stage 3 C1 post 6 cycles of carbotaxol with early recurrence in the pelvic and para-aortic nose. Please observe the concomitant boost which is delivered to the area of nodes to 55 Grays, while other areas are receiving 45 Grays. Stereotactic body radiotherapy is another way to deliver salvage radiation therapy. Is usually high dose of radiation to the small volumes, can be given to pelvic or para-aortic fields. Those dose schedules are pretty much retrospective data from other centers. You can even retreat to 24 Grays in 3 fractions in already previously irradiated patients. This is an example of para-aortic nodal recurrence. Please note very conformal dose distribution with high dose inside of the target and very rapid dose follow outside of the target, thus sparing the kidneys, the liver, the pancreas, and the bowel. Here is the summary table of salvage rate. It is a mix of both vaginal and pelvic recurrence with 5 years local control up to 84% and overall survival up to 66%. There is one trial which is maturing right now, and this is a phase 2 randomized controlled trial with 164 patients, the GOG-0238 trial. Patients had vaginal and pelvic recurrence only, and they were randomized between radiation therapy to the pelvis and brachytherapy versus radiation therapy to the pelvis, brachytherapy, and concomitant chemotherapy like weekly cisplatinum, similar to what is used for cervix. Surgery is permissive. Primary outcome was duration of progression-free survival, and the results are expected in January. So quickly, the conclusion of the ASTRO guidelines. I think actually for the sake of time, we probably are not going to read them. You have them in your handouts. Those guidelines actually were confirmed by ASCO in JCO in 2015. We have similar conclusion from the Comité d'évaluation des pratiques en oncologie from Quebec, and similar recommendation came also from Alberta and Europe. My final slide is the Society of Gynecologists and Oncologists recommend the following follow-ups. In our institution, we see the patients every 3 months for the first 2 years, every 6 months for additional 3 years, and yearly thereafter. Why am I pointing this out? Because visits are alternating between the treating gynecologists, oncologists, and radiation oncologists. Pap test was not found to be useful in follow-up and is not done routinely. And for CA-125 and radiological tests, there is no evidence of benefit in follow-up and can expose patients for unnecessary further investigations and treatment.